Hi, my name is Dr. Jory Fleischer. I'm a movement disorders neurologist at Rush University in Chicago, and thrilled to be able to talk with you about psychosocial implications of early onset Parkinson's disease. So here are my disclosures. So let's talk first about the overall impact of early onset Parkinson's in the context of the broader disease. So I really like this study that was done by Knipe and colleagues, and they illustrated many different factors that contribute to overall quality of life in someone with Parkinson's disease in general, and then certain factors that may be even more prominent in people with early onset disease. And by early onset or young onset, which are used interchangeably and throughout the literature, here most of the time we mean age of onset before age 50. And that's based on a recent paper that was published by the Movement Disorder Society Early Onset Parkinson's Disease Task Force. So in this paper, they used an onset less than age 45. But what they found was that individuals with early onset PD had a more than twofold risk of poorer quality of life compared to individuals with later onset Parkinson's disease. However, they found that this was attenuated by depression. And we'll come back to mental health issues in early onset PD, but our folks with early onset are more than twice as likely to have depression compared to other individuals with Parkinson's disease at a more routine age. So there are many reasons why quality of life may be more affected in individuals with earlier onset. So they're more likely to be navigating multiple caregiving roles. So they may be caring for children, they may be caring for parents, they're in the prime of their working career. If they're working outside of the home, they are more likely to be employed than someone with later onset. And all of these things can have greater impact on their family life and relationship conflicts. And for many of us as movement disorders neurologists, we were trained that, if you see someone with early onset PD, you can reassure them because it's going to progress more slowly. Typically, symptoms are milder, right? And all that is true. However, because these individuals have a longer duration of disease, by the time they reach a traditional age of Parkinson's in their 60s or 70s, they've been grappling with these symptoms for far longer. They've advanced more. And so they face greater physical, psychological, social, and economic consequences. And although the classic teaching was that people die with Parkinson's, not from Parkinson's, that's since been proven wrong in general, but also particularly in folks with early onset PD. In a study by Mahana and colleagues in 2014, they looked at individuals, and here early onset was defined as less than 49. But in a retrospective analysis, they found that indeed our folks with early onset survive for quite a long time. Their mean survival is 32 years. However, when comparing to the median US survival for similarly aged men, and this cohort was mostly men, there was a 15-year age difference. So a 15-year change in life expectancy among people with early onset PD. Now, granted, this is a small study. It's older. It was done only in the US, but it does give us a sense that this classic teaching of dying with but not from Parkinson's may not be entirely true. And this has a dramatic impact not only on people's quality of life, but potentially on duration. So let's start at the beginning because there's a beautiful qualitative study by Valasaki. And in this, she interviewed 17 individuals with early onset PD to explore the processes and the experiences of searching for and receiving a diagnosis. And she describes this diagnostic process as the detecting phase. And this is closely related to a concept called biographical disruption. And that's the idea that from the onset of symptoms, the uncertainty of what's going on and what's causing it, to seeking help, sometimes repeatedly, to the relief of or shock of an adjustment to a diagnosis, a chronic illness like early onset PD or EOPD disrupts a person's own biography. So some people experience this in a binary way. I was fine up until that day that I noticed the tremor, and everything changed after that. My whole life was different after that. But for other people, it's a repetitive process where who we are as a person gets redefined every time a new symptom appears, every time an adaptation has to be made to daily living, every time the illness impacts a relationship. And this biographical disruption, especially coupled with the fact that individuals with EOPD frequently have their symptoms misattributed to psychological causes. This can all be incredibly traumatic for many, many people with early onset Parkinson's. So, again, there's this idea that there's the onset, the perception of bodily symptoms where someone knows something is off, something is different. I don't know what this is. I'm afraid of what this is. And then they go searching. And that searching can be online, it can be Uncle Google, it can be WebMD, who knows where it is. It can be healthcare visits, often repeated healthcare visits with folks who may not recognize the symptoms of early onset PD and lay explanations for why their symptoms are happening. And then finally, this official diagnosis. And different from later onset PD, for many people with early onset PD and qualitative studies, they actually describe a sense of relief at the time of diagnosis. Not, ah, everything is wonderful in my world, how wonderful that I have Parkinson's, but they have been told this is all in your head. This is anxiety. This is a psychiatric condition. This is a psychological problem. There's nothing wrong with you. You're too young to have Parkinson's. So that when someone finally aligns the symptoms that they're having with an actual diagnosis, there is that sense of relief. Why are we talking about this, right? Because someone is coming to you, presumably you're making the diagnosis or you're taking someone on who has this diagnosis. Just being able to recognize and validate the journey that they may have gone through before they've made it to your clinic room and the complex psychological processes and the trauma that may have happened as a result of this, often for many people for years, can be tremendously validating and really help instill trust and build that therapeutic relationship that you need with this person going through for the years and decades to follow. So, let's talk about social cognition and how that changes in people with Parkinson's. So, there's no specific literature, to my knowledge, on social cognitive changes in early onset Parkinson's specifically, but we do know some things about social cognition in Parkinson's in general. So first, what do I mean by social cognition? This includes theory of mind, so understanding another person's intentions or emotional state, being able to essentially read their mind. Empathy, which is our emotional or cognitive response to that perceived state of others. Social perception, picking up on social and emotional cues, on body language, on facial expression, and then social behavior, interpreting all of that and being able to act in response to it. And so what we know is that in general, Parkinson's actually does affect theory of mind and empathy and facial emotional recognition and processing. So people have found that even among non-depressed individuals with Parkinson's disease, there is a reduced ability to recognize facial emotions and particularly anger. Researchers have found that people with PD have less visual scanning of the face. So when they're having a conversation with someone, they're more likely to be staring at the middle of their face and less likely for their visual fields to be darting around looking at the set of a person's mouth, looking at whether their eyes are crinkling in laughter or their forehead is wrinkling up in anger. And so they're focusing on the center with less attention to the mouth, meaning that many nonverbal cues are being missed. And another aspect of social cognition is mirroring. So here's an example. Former President Barack Obama was widely recognized as having lots of photos with kids, really enjoying being with them, and often is seen mirroring the children's facial expression with his own. This is one of the ways that kids learn how to impact their environment. They smile, people around them smile. And this is part of what we do in normal social interactions. But because people with Parkinson's have reduced facial expression, because they have that hypomimia, they may not be mirroring what other people around them are showing in the conversation. And that may impact the interactions that they're having and other people's willingness to interact with them. So, diminished facial emotion recognition and processing, diminished empathy, and theory of mind may impact relationships in individuals with early onset PD earlier and more significantly. And interestingly, in a 2010 study of only 60 individuals in the US with early onset PD, 63% of whom were men and 85% were in a relationship. And here they had a mean onset of 43 years when their Parkinson's symptoms began. 57% rated their primary significant relationship as either having a satisfaction of poor relationship satisfaction or worse than poor. And among 32 couples, the relationship satisfaction between the person with early onset PD and their partner was highly correlated. Interestingly, depression correlated with both relationship dissatisfaction in the individual with EOPD and in their partner. And so there are numerous issues that contribute to relationship satisfaction. And a prominent one for everyone with Parkinson's, but perhaps more importantly, in individuals with early onset Parkinson's disease, is sexual dysfunction. So there are numerous issues that contribute to sexual dysfunction in Parkinson's, some of which, however, may be more pronounced in this population. So we know that depression is twice as common in early onset PD, and depression contributes to decreased libido. However, we also know that a common side effect of antidepressants is decreased libido. Bradykinesia, rigidity, and dyskinesia can all impact movement and sexual arousal. Hypomimia and non-motor symptoms such as sialorrhea, constipation, urinary urgency, or dysfunction can alter both the individual with EOPD's self-esteem and the partner's degree of attraction. There are often shifting roles where if the partner feels like they have to be taking care of the individual, they may have a diminished sense of intimacy and libido towards their significant other because they're wearing that care partner hat instead of the partner hat. Furthermore, um, erectile dysfunction is very common, including in our individuals with early onset PD. And so this can impair arousal, as can impaired lubrication in women, and that can be a significant barrier to intimacy. Additionally, and of particular relevance in EOPD, is that these individuals are at a much higher risk of impulse control disorders, which can have significant negative consequences on their relationships. And both the person with EOPD and their partner may be juggling many, many demands. Parenting demands, caring for aging adults, the stress of professional obligations, all of which can compound all of these issues. So it shouldn't be surprising then that in that same 2010 study that looked at relationship satisfaction in general, 37% of people endorsed poor or worse sexual dissatisfaction. And that correlated, not surprisingly, with relationship dissatisfaction. And there's the thought that perhaps this is more pronounced in EOPD because people are likely to be in shorter term relationships than if someone has diagnosed with Parkinson's in their 60s or 70s. And shorter relationships, shorter marriages may be more susceptible to strain. However, at this time, there is not any evidence suggesting that people with EOPD are at a higher rate of divorce or are more likely to be single. Indeed, we have one study from back in 2003 that showed that the rates of divorce were the same. However, that's quite an old study, and certainly based on feedback and clinical experience from many of us who see people with EOPD, this is something that really needs to be studied. There is a sense that people may be more likely to be on their own. So, moving from relationship issues and sexual dysfunction to family planning concerns. The incidence of pregnancy in Parkinson's disease is quite unclear. However, we know that there are at least 400 women diagnosed with early onset PD in the US every year, which means many of those women are within childbearing years. In small studies that have looked at the experience of pregnancy in Parkinson's, 65% of women experienced symptom exacerbation during their pregnancy. However, it is really critical to recognize that many people said that this happened in the setting of their medications either being weaned substantially or all of their medications being stopped. So, certainly there can be physiologic explanations for worsening of symptoms in pregnancy. This could be related to altered pharmacokinetics of dopaminergic therapies, plasma volume expands. We know that gastrointestinal absorption changes during pregnancy and renal clearance is altered. However, the only evidence that we have so far really seems to suggest that among those who have worsening of their symptoms in Parkinson's, Iatrogenic changes, reducing medications, taking their medications away, may be the primary driver of worsening Parkinson's symptoms during pregnancy. Furthermore, in the studies that have been conducted, neither Parkinson's itself nor levodopa increase the rate of infertility, spontaneous abortion or fetal loss, or fetal or maternal complications. Based on the information that we have at this time in October 2024, levodopa is safe in pregnancy. Furthermore, healthcare professional experience caring for women with PD who are pregnant is minimal. In the studies that have been done, I'll point your attention to this study by Young and colleagues published in 2020. They really did a tremendous job reaching out to numerous national societies of obstetricians and gynecologists, national society of anesthesiologists and neurologists, trying to ask for people who had experience caring in any of those capacities for pregnant women with Parkinson's. And the survey response rate was quite low, but even among the responders, their experience caring for such women was very low. They responded to the survey saying, I'm at least interested in this, but no, I haven't taken care of any women with Parkinson's who are pregnant. So we really need to do a better job, and people are trying. So there is a brand new study coming out of the Netherlands where women can register if they are pregnant and have Parkinson's. It's www.pregspark.com. It is a registry for pregnant women with Parkinson's disease, and they self-complete information, and they will be followed to look at some of these really important questions. So one development that is quite recent is that the Movement Disorder Society Early Onset Parkinson's Disease Working Group did conduct a review of the literature trying to identify any evidence that we could find on managing pregnant women with Parkinson's and deep brain stimulation, or DBS. And the recommendations based on that lit search are as follows: that really there must be adequate planning and collaboration, not only between the neurologist and the obstetrician, but ideally between anesthesiology, just in case. That regular checks of the IPG, or implantable pulse generator, are done pre-pregnancy if possible, and every 3 months antepartum, to make sure that there are no sudden battery depletions. That programming is safe and can be performed in pregnancy as needed. That vaginal delivery is preferable, but in the event of C-section for other reasons, bipolar cautery is preferred in order to reduce the risk of electromagnetic interference. And finally, the presence of an IPG, the presence of DBS alone, should not be a reason to discourage breastfeeding. So moving from pregnancy onto children. Disclosing Parkinson's to children, especially among folks with early onset disease, is very, very challenging. And many of us who care for these patients know that the parents with EOPD will hide this diagnosis from their children for quite a long time. And when they do finally disclose, their children disclose to them that they knew something was going on. And the lack of sharing it with them, the hiding, the seeing changes in mom or dad, but not being told what was happening, led them to fear the worst. I've had countless patients who've told me, my kids thought I had cancer. My kids thought I was dying. And so really we need better resources to help our patients and families talk with their kids about their diagnosis and reassure them. And so here are some general guidelines. For younger children, don't hide it from them. Children are tremendously intuitive. They may worry more about what they don't know. But thinking about the conversation, planning out the disclosure conversation, we can try to anticipate specific concerns. So depending on the age of the kids, they may want to know, okay, daddy has Parkinson's. Does that mean that he can't come to my baseball games? Or mommy has Parkinson's. Does that mean that she's not going to be, classroom mom, or show up to, dance class with me? Does that mean that we can't go on the vacation that we planned? Right? Thinking about what is salient to that child and what they might jump to, and having those answers at the ready when planning the conversation can be really helpful. Kids may ask whether it hurts, whether people are in pain, and what this has to do with mortality. So being able to have open, honest conversations about that at a level that's appropriate to the kids is really important. Parents may want to ask for the children's observations or concerns as a starting point. Have you noticed anything about daddy? Have you noticed that mommy's hands have been shaking? What did you think about that? What were you concerned about? Let's talk about it. Using clear, simple, but specific language, using the word Parkinson's, encouraging them to ask questions, and letting them feel in control of the volume of information that's shared. And really importantly, our patients don't have to do this on their own. Um, so, one great resource for kids, I would say, sort of 7 and younger, is this book called My Grandpa's Shaky Hands. This is written by Dr. Sonia Mather. It's particularly remarkable because Dr. Mather is herself a physician and an author and someone living with early onset Parkinson's disease. And furthermore, for kids older than that, Dr. Mather co-authored this book, Shaky Hands, with her own children as a resource for older kids to understand Parkinson's disease. So these are available wherever you might order books from, and they're quite helpful. I keep a copy in my own clinic to share with people as an example. And then for teenagers and adult children, the conversation may focus on what they can do to help. And so thinking about that, um, there may not be anything. It may just be, I want you to know this, and I don't want you to treat me any differently. Or I want you to know this, and I would really love it if you could XYZ. And letting our patients know it's okay to ask for help. So that brings us to mental health. So we know, and I've mentioned a few times, that depression is twice as common in people with early onset PD. But in a really pivotal study, a US-based epidemiologic study that looked at the disabled Medicare population, conducted by Allison Willis and her colleagues, they identified 14,354 people with early onset PD who were on the Medicare rolls. They found that 40.7% had depression, 17.4% had substance abuse or dependence, and 19% had cognitive impairment or dementia. And comparing this population, so that's over here, comparing this population with the remainder of the young disabled Medicare population, so other individuals with chronic or serious illness in this same age range, individuals with early onset PD had a more than 7-fold increased risk of cognitive impairment or dementia, a more than 3-fold increased risk of substance abuse or dependence, and a nearly 2-fold increased risk of depression, even after adjusting for race, gender identity, and age. Additionally, this same study examined hospitalizations within this population and found that among the 14,354 people, there were 12,322 hospitalizations in the year 2005 alone, and 32% of those hospitalizations in people with EOPD were for psychiatric issues, with psychosis being the most common issue and accounting for 11.6% of all hospitalizations. So it must be noted, of course, that this group is not representative of all individuals with EOPD, as this study was limited to those individuals impacted enough to be receiving Medicare for disability. However, we do know that depression is incredibly common. Impulse control disorders are far more frequent in those with EOPD than the general population or in later onset PD. And generalized anxiety, panic disorder, substance use and dependence, and adjustment disorder are all more common. And these can have significant ramifications. So, among individuals with early onset PD who were not yet retired, compared with people who had later onset PD, those with early onset were far more likely, 56% reported that there had been at least some period where they'd been employed for more than 6 months due to their disability, whereas only 7% of people with late onset PD reported the same. And 73% of people with late onset PD reported that they retired early. However, 97% of people with early onset reported that they retired early. And pound for pound, those individuals with early onset retiring earlier, that has a far greater financial impact on their family than those who maybe retired earlier than age 65 or age 70 than they planned, but that's a year or two. So in a subsequent 2006 study, 54% of people with early onset PD reported that they retired early, and 94% said that they were likely to give up work within 10 years of onset. In a separate study here, shown in this Kaplan-Meier curve from Jasinska-Miga and colleagues, they didn't specifically focus on early onset PD, but rather on the loss of the ability to work. And the authors calculated these survival curves where the y-axis represents the proportion of individuals still working. And so here in purple, I've tried to highlight both the curve and the numeric values for folks who are sort of closest to our early onset group. So these are people with onset before age 70 in this study and disease duration greater than 4 years. But again, still not quite early onset. And the mean age of first visit in that population was 71 years old. Still, we can see if we look at this group of younger with greater disease duration, still when we follow them out to 6 years, where we're here, about 60% are still working. By the time we reach 10 years, we're dropping down to about 20% still working. Of note, additional risk factors that predicted a future loss of the ability to work were dementia, according to clinician rating, a Hoehn-Yahr score greater than 2, meaning someone is starting to have postural instability, higher just postural instability score on the Unified Parkinson's Disease Rating Scale, and a higher total Unified Parkinson's Disease Rating Scale total score. So what does this mean? Beyond mental health challenges, beyond postural instability, beyond cognitive impairment that could be contributing to that earlier time of retiring, there is tremendous stigma related to Parkinson's. And so that stigma becomes internalized. That becomes part of that biographical disruption where people see themselves differently and leads to a reluctance to disclose their diagnosis to their employers, which means that there's a reluctance to ask for appropriate accommodations. And without appropriate accommodations, there's an increased risk of unemployment. And when our individuals lose employment, that has a tremendous impact on them and their families. So when we look at the total cost, the direct economic cost of early onset Parkinson's disease, 65% of that is accounted for solely by the loss of earnings of that individual. And if that individual's income is a large part of their family budget, that piles on tremendous economic stress, tremendous further strain on their relationship or their marriage. However, we should caution ourselves and our patients that this curve may not be unbendable. So in an Irish study examining factors related to employment and Parkinson's disease, among those who were employed, 77% said that they had made adjustments to remain so. And among individuals who were unemployed, 67% felt that adjustments would have prevented their job loss. And 82% of those who were unemployed were dissatisfied. Our people with EOPD want to be working. They want to be contributing. They don't want that biographical disruption of no longer being their career, their profession, how they identify themselves before Parkinson's butted in. So we need to encourage them to find ways to accommodate, to ask for what they need so that they can continue to be who they want to be and do what they want to do. So one way, at least in the US, that my social worker has sort of found a sneaky way around this is to encourage people to use their open enrollment period to ask about benefits, ask about short and long-term disabilities offered by different plans, just out of curiosity, exploring those options before they disclose their diagnosis so that they can choose a plan that works best for them before they come out with their Parkinson's. If someone is self-employed, they may want to explore private disability insurance, although this can certainly be cost prohibitive. And as physicians, as their healthcare providers, there is a fine line to walk because for many people, they may not want us documenting much of their impairment in the medical record for fear that this will be disclosed and that this could lead to job loss. However, if down the line they are applying for disability, we need to be able to show a track record of their function. And so we really do want to document their impairments correctly and accurately in the medical record for their future needs. So acknowledging with our patients that this is a difficult conversation and people may not want to think forward to that future possibility, but like an insurance policy, we want to set them up for success so that if down the line they need to apply for disability, the paperwork, the paper trail is there for them and they can be successful and obtain what they need. Finally, something that comes up often is this idea of vocational retraining, meaning referring someone to an occupational therapist who can sort of assess what it is that the person does, what their skill set is, how Parkinson's might have changed their abilities, and what different career path might still be a good fit for them. And this is really important. And this can be a very useful resource. However, we need to think about this realistically. Vocational retraining is not available everywhere, and the wait list may be long. And vocational retraining could take months, 6 months to a year. So if someone is going to get on the wait list for vocational retraining, we really, as their healthcare providers, as a movement disorder specialist, as their neurologist, as their allied health team working with them, really need to think forward a year and a half, 2 years, and try to project out into the future. What would be a reasonable skill set to assume that they will have at that point? What would be reasonable in terms of a job that they could hold 2 years from now if symptoms keep progressing at the rate that they have been? Because the last thing we want to do is put someone through a wait list, put them through vocational retraining, have them reconfigure their biography of, okay, I'm no longer a physician, but I'm going to work in medical education. I'm no longer able to work on the line in production, but I can do the following, only to spend 6 months, 12 months, 18 months, come out the other side and not be able to do that job that they've retrained for. So we want to avoid the demoralization that could happen from that and really be realistic with them and think forwards. So, um, this is a figure that I really like, and this comes from the palliative care literature within Parkinson's and sort of neuropalliative care in general. Why would I bring up neuropalliative care in a talk on early onset Parkinson's? Well, traditionally, we've thought about palliative care as a dirty word, as a term. We link it with hospice, and well, that definitely means the end, right? And so traditionally, we don't bring up palliative care very much at all in Parkinson's for many, many years. And if we do, we bring it up here towards the end when needs are really dramatically increasing and we're seeing an accelerating decline. However, what the evidence tells us is that there is a palliative care need throughout the course of the disease. And indeed, that need starts even before the time of diagnosis. If we think back to those early slides, it starts at the time of onset of symptoms when someone is going, what is going on? Why is my hand not functioning the way it's supposed to? Why am I not able to do my job as a dental hygienist? Why am I having trouble taking notes? What is this going to mean for me? What is this going to mean for my kids? What is this going to mean for caring for my loved ones? That holistic need and addressing not only the physical symptoms, but the mental symptoms, the social symptoms, the economic consequences. All of that is palliative care, and palliative care needs are present from the onset of symptoms, the time of diagnosis, and all the way through, particularly for folks with early onset Parkinson's. And as we keep in mind that holistic approach that palliative care shares with us, please don't forget the care partners. So, care partners in early onset may often be referred to support groups and find that the other care partners there are in their 70s or 80s. And it's just a different fit. They're in a different stage of life than care partners to someone with onset in their 40s. And so we need to validate and make sure that those care partners coping with EOPD know that they are not alone and provide them with resources that can be helpful. So lots of resources to share at the end of this talk, but a couple to just shout out and bring to your attention if you're not aware. I had the real pleasure of working with the Davis Phinney Foundation on this care partner training, which is an online, entirely free course that people can take asynchronously at their own pace and covers a ton of different topics, not EOPD specific, but that are relevant to EOPD. And that they can go through, pick topics that feel relevant, skip the ones that don't, but know that it's there for them. And finally, I would be remiss if I didn't shout out my own NIH-funded study, which is really directed at care partners whose loved ones have cognitive change or dementia with Parkinson's. And so this is not specific to early onset, but it is certainly open to our folks with early onset. And this is an entirely virtual study open to current and past caregivers with PD, dementia, PD with cognitive change, dementia with Lewy bodies, Lewy body dementia. And we train our experienced care partners to serve as mentors to newer care partners. And those newer care partners are either randomized to being mentored and having a really rich, specific curriculum that's been tailored to them for 12 weeks, or even the control condition gets a 12-week curriculum and a list of targeted, validated resources that we've vetted and we know are trustworthy and we know are helpful for them. So folks can check out that QR code or check out that link. All of the enrollment is all online, all participation is virtual. So please feel free to share with all US states and territories. So finally, lots of reasons to be concerned about our folks with EOPD. This impacts them in so many ways, and so many ways that can be negative. However, I think one of the things that keeps many of us going who take care of folks with EOPD is just the awe and the inspiration of seeing so many people who've used this diagnosis as an inflection point in their life. And so for so many people, because we have a longer time horizon with them, because they have years and years and years where hopefully symptoms are slowly progressive, that gives us, it's incumbent on us to identify opportunities for growth. And thinking about this in a palliative lens, growth not just in how we can help them physically, not just in how we can help them mentally, but in how we can help them socially and how we can help people with EOPD help each other and advocate. So, exercise. Exercise is the one thing that we have proof in Parkinson's seems to slow down the course of disease. And we have time in our folks who are early. They may already be avid exercisers. If they're not, we've got more years to get them to exercise and bend that curve. We have the opportunity to help them connect socially, either leveraging the social connections and networks that they already have, irrelevant to PD, and building up their social strength to prevent against social isolation, or connecting them with support groups, with buddies, with peers, with mentoring programs, with foundations and organizations, particularly those that focus on folks who are earlier onset. We can connect people with psychotherapy, not only to cope with the diagnosis of Parkinson's and how they move forwards and the mental health challenges that may accompany it, but to help them heal prior wounds so that they can go into their Parkinson's more equipped. Finally, we talked a little bit about the impact on employment, vocational rehab, but helping people think through if they need to have a career change, how do we plan that? What does that look like to them? Is there something that's meaningful that they never thought that they'd actually get to do, but maybe now this provides an opportunity to explore in a different direction? We can encourage our folks about the importance of research participation, not only for them, but also to shape this disease and make it better for generations to come. And that can be a tremendous source of meaning and legacy building. And finally, advocacy. So no matter how many doctors in white coats show up to lobby Congress, the thing that is going to be most impactful from an advocacy perspective is a person living with the disease who is sharing their own personal story and demonstrating what the impact of legislative change or advocacy or policy could have on them and people like them. So, encouraging our folks with EOPD to become involved in advocacy at the local, at the state, at the national level, whether that's through organizations or on their own. There are so many ways to do this. There are many routes for this, and I'll provide some resources in the show notes. But encouraging people to get involved in advocacy. And I can think of no better example than Michael J. Fox, who, as recently as January of this year, said Parkinson's has been a gift that keeps on taking. It's been a gift because it's given me an audience to talk about what's possible. So with that, I want to leave you with a few conclusions that individuals with EOPD are often juggling professional, relationship, parenting, and caregiving relationships simultaneously while trying to cope with this new diagnosis and symptoms. The diagnostic journey before they ever get any label can be long, traumatic, and associated with significant biographical disruption. Social cognition, including theory of mind and empathy and facial recognition, is altered in Parkinson's, and that may be driving some of the impact on relationships. Family planning and pregnancy concerns are underappreciated and under-researched, but levodopa and DBS programming are safe in pregnancy. Disclosure and stigma present sizable obstacles in both family and social and occupational settings. And despite longer disease duration and slower progression, EOPD has a dramatic impact on quality of life, depression, psychiatric hospitalization risks, unemployment and early retirement, economic hardship, and relationship satisfaction. However, with this longer disease duration, we have the window to introduce opportunities for growth, for connection, and for meaning and for action. So there are resources available for individuals and families with EOPD. There are resources and available to healthcare professionals serving them. Thank you by watching this video for being one of those healthcare professionals and serving them. So with that, I just want to acknowledge the Movement Disorder Society Early Onset Parkinson's Disease Study Group. They are open to new members. So if you are a member of the Movement Disorder Society and interested in working on some of these issues, please come join us. And to the amazing team that I am lucky enough to work with and be supported by, and my kids who continually encourage me to look to the future and make things better for future generations. Thank you so much. There's my email and Twitter X handle. Feel free to reach out. Thank you.